All right. It is 1:30, so I think we're going to get started. I want to welcome everyone to what I think is a particularly stimulating topic when it comes to our field of pediatric anesthesia, one that lends itself perfectly to a debate, whether total intravenous versus inhalation anesthesia is the best practice in pediatrics. If you had to choose which of these two approaches would be your favorite, which lends itself the best? Each approach carries its own philosophy, advantages, and challenges. And today we're fortunate to have two experts who are going to help us explore both options. Speaking in favor of total intravenous anesthesia, TIVA, is I'm delighted to introduce Dr. Linné Correll, a pediatric anesthesiologist at the British Columbia Children's Hospital in Vancouver and a clinical associate professor in the Department of Anesthesiology, Pharmacology, and Therapeutics at the University of British Columbia. Dr. Correll trained in both pediatrics and anesthesia in Rochester, New York, where she also practiced several years before becoming immersed in the TIVA life on the west coast of Canada. She has since acquired lots of experience incorporating TIVA in a wide range of pediatric cases. She also serves as the director of Periprocedural Integrative Medicine Clinic at BC Children's and is the co-director of the Pediatric Anesthesia Research Team. Her research interests focus on using integrative medicine techniques to help patients and families better prepare for the stress and challenges of surgery. Outside of work, Dr. Correll enjoys running, watching her son play soccer, and baking treats, which she insists on sharing with her colleagues to keep them out of her kitchen. The treats, that is, not her colleagues. Arguing in favor of inhalation anesthesia. Yeah. We are joined by Dr. Kurt Lalwani, a pediatric anesthesiologist at Oregon Health and Science University in Portland. Dr. Lalwani is a professor of anesthesiology and vice chair of faculty development at OSHU, where he also serves as the program director for the Pediatric Anesthesia Fellowship, which he founded in 2002 and has been leading now for over 20 years. Dr. Lalwani trained in London in anesthesiology at King's College and in pediatric anesthesiology at Great Ormond Street Hospital for Children. His academic interests include pediatric sedation, operating room communication, and distractions, as well as mentoring and outreach for high school, college, and medical students. Having lived and worked in 3 continents, Dr. Lalwani joked that he has only 4 more to go. When not in the operating room, he's an avid traveler who has visited more than 70 countries. That is hard to beat. Many on scuba diving expeditions, even harder to beat. He's also a fan of international police procedural and crime shows, watching their native languages with subtitles courtesy of Netflix. Each speaker will now have the opportunity to present their perspective, followed by questions and a debate with the audience, which we'll leave for after both presentations. So without further ado, let's begin with Dr. Correll to share the case for total intravenous anesthesia.
Okay, so we determined that if I didn't have a stool, and there is no stool, it would be like a voice from behind the wall. So I'm gonna stand on this suitcase and hope that I don't crush it. And then we'll go from there. Let's just make sure. Oh. Okay, so I think, Sophie, thank you for that awesome introduction. As Sophie said, I'm Linny. I am from the British Columbia Children's Hospital. I am super thrilled today to talk with Kirk about one of my favorite topics, which is TIVA. Obviously, you know which side of the debate I'm on, but I am going to let you in on a little secret. I have not always been a TIVA devotee, in fact, far from it. I've only been in BC Children's for about 3 years, and it was moving to Vancouver that was the impetus for a total practice and attitude change for me about TIVA. I used to be a person who used it begrudgingly as required for certain types of cases, and now I use it more than 85% of the time with a smile, and here I am to try to convince you to do the same. So as an admitted skeptic, at least at one point, what qualifies me now to stand here as an expert? I actually think that a convert like me is probably the perfect person to proselytize, because my move to using TIVA was deliberate and a conscious choice that I made based on the evidence, as well as landing myself in a place with lots of experience and a large group of people who have been doing this for a very long time, and who are able to navigate some of the things that people who are not yet using TIVA feel are their biggest obstacles, like IV starts and stuff like that. But enough about me. What are you going to get out of this talk, right? Because you even came to this debate, I already know that you have opened the door in your minds to the idea that there has to be something better than what you're already doing. Oh, we have nothing? Oh, we have slides. Okay, got it. And that something better is definitely TIVA. By the end of this section of the session, you will know at least 3 concrete reasons why TIVA-driven general anesthesia is better for kids than volatile, why it's better for the earth than volatile, and you'll know why practicing TIVA is actually better for you as the practitioner. The ASA instructions for this year were a little different than previous years. Usually they want a whole bunch of financial disclosures. This year they actually said they didn't need slides for disclosures, and that's totally fine. I have no financial or other disclosures at all. But I do think it's important to mention that when we talk about some of the medications today, or when I talk about some medications today used in children, we may be doing that off-label. And specifically in this talk, or maybe the debate that's going to come after, you may find that some of the things that I talk about doing at my institution are things that you may be strictly prohibited from doing at your institution. So I need to be very, very clear. I am in no way instructing you here to do anything or all of the things that I mention, but I think it's really important that people know what's going on outside and what people are doing at other institutions. You do you, boo. To start, I feel always really compelled when I talk about TIVA to mention this paper written by my fabulous colleague, Dr. Jillian Lauder. Those of you who are paying attention or who have excellent eyesight will notice that this was written in 2015, which may seem like an awfully long time ago now, I guess, right? So if TIVA were so great, we probably should all have been doing it all the time. It should take over, right? I don't know. I actually don't agree. 10 years is not a terribly long time when you're talking about big system changes. And there actually has been a huge uptick in the use of TIVA, and so now we're going to talk about why. Let's get into it. In theory, you probably already know a number of advantages to using TIVA. There is more and more literature on the topic every year, which is giving lots of quantitative backing to people's sort of anecdotal personal experience. I'm going to address the 3 of these in turn, but I will be very upfront in saying I did not design this talk to throw out every article ever written on each of these topics so I could stand here and just sort of run through them and say, these are the reasons why TIVA is better than gas. That's boring for me. It's overwhelming for you. You can go read the papers. There's no point. What I suspect is what you're looking for is evidence, yes, but also some digestible take-home messages that you can turn into something you operationalize in your own practice, and so that's what we're going to spend most of our time on today. First, and probably most compelling though, is that there is improved safety related to perioperative adverse airway events with TIVA. Since the most devastating complications during our perioperative period with kids typically have to do with respiratory issues, the fact that they are less common when TIVA is used is very important. In this classic study by Ramglam et al. In 2018, they showed that children getting IV propofol induction were significantly less likely to experience perioperative respiratory adverse events when they were compared to kids getting inhalational sevoflurane induction. And this was true for both major events like bronchospasm and laryngospasm, and also some minor events like coughing or short periods of desaturation. But you might be thinking, Linny, it says right there in the title that these kids were already high risk for respiratory events. That doesn't apply to my population. Well, my response is actually to look closely. They defined high risk in a way that's probably different than what you do in your mind. They use things like passive smoking, family history of hay fever, and other really incredibly common characteristics, which makes, I think, this study even more generalizable than maybe someone would think just sort of by looking at the title alone. But if that's not enough for you, other papers have found more evidence of the same. This one in 2022 looked at adverse respiratory events in kids during LMA removal, and in this case, the adverse respiratory events when removing the LMA were significantly less likely to happen in patients who underwent TIVA for maintenance than those who had inhalational gas anesthesia. And the difference was actually pretty significant. It was 11% versus 35%, so that's a big difference. Okay, so fewer respiratory complications. That alone might be enough for someone to favor TIVA, and there are certain cases where probably that is why you would choose TIVA. But obviously I have to fill 20 minutes, so we're not going to stop here. Let's move on to the second of the big three advantages, and that is a reduction in emergence agitation. In this randomized controlled trial, children underwent induction plus maintenance with either TIVA, no inhalational inductions here, or sevoflurane. And here you can definitely see that the patients in the TIVA group were far less likely to have emergence delirium than those who had sevoflurane. For those of you saying, but that was ages ago, I got you. Here is a more recent study where this again was confirmed. In this one, children either were induced and maintained with gas, that's group A, induced with propofol but maintained with gas, that's group B, or induced and maintained with propofol both, and that's group C. And again, it's easy to see here that delirium was much less in the TIVA group. Okay, so that's point number 2. There's less delirium with TIVA. We should probably keep it coming because I still have not filled the 20 minutes. Why else is TIVA better in kids? How about less throwing up? Everybody loves less throwing up, right? And you guessed it, there is less throwing up with TIVA than with gas. Let's check out the results of this systematic review. In this one, the authors amalgamated the results of 4 randomized controlled trials where patients were given either sevonitrous or propofol nitrous, and they found the odds ratio of developing post-op nausea and vomiting was almost 3 times as great in the patients getting inhalational anesthesia versus those getting TIVA. Now, if you remember just back 7 or 8 minutes ago, I said I was going to leave you with 3 concrete reasons why TIVA was superior to inhalational anesthesia. But what if I told you there was a bonus round? Everybody loves a bonus round, right? Okay, there's a bonus round. Here you go. Let's talk about pain. This is a study, here is a this is a study, it's a meta-analysis of 13 randomized controlled trials, over 1,000 kids who were included. And I think you probably know what I'm going to say, but here we go. I'll give you the stats just to be professional. There was a nearly 2-fold higher risk of overall postoperative pain in the sevoflurane group amalgamated over all these studies compared to the propofol group. In addition, the kids who had pain, the ones with sevo, had higher pain scores than the kids who had pain in the propofol group. And the kids who got sevo were 60% more likely to need rescue analgesics in PACU. All right, I rest my case, I guess. So we talked about why TIVA is better for our patients. I could also stop here, but I'm going to stop talking about how I could stop because Sophie will have me stop. All joking aside, we are primarily dedicated to the well-being of our patients. That's what drives us, and that's probably why we go to work every single day. But there's compelling evidence that TIVA is better than inhalational induction than inhalational anesthesia for lots of reasons. And since we are humans and thereby complicated emotional creatures, it is obviously about more for us than just the well-being of our patients. Because of that, I'm going to use the next few minutes to espouse another benefit of TIVA, and that is the benefit to our environment. We need to obviously keep our world green for all the kids out there and maybe also the ginormous bunnies. In 2017, the NHS in England commissioned a group of people to understand the carbon footprint of surgery. As part of that study, overall contributors to the footprint were investigated, and lo and behold, it was found that anesthetic gases contribute 525 kilotons of carbon dioxide equivalents to the NHS carbon footprint, of which 200 kilotons of carbon dioxide equivalents arose from the surgical use. This total incorporated both nitrous and volatiles, but the volatiles made up about 20%, so it was still actually worth talking about. Globally, anesthetic gases are estimated to contribute to 0.6% of healthcare's total climate change impact. The anesthetic gases vary a little bit based on which volatile is used and whether nitrous is used or not. But the bottom line is that we need to worry about the gases. Now I hear some of you in the back, what about the plastics? What about the groundwater? What about the waste incineration? Doesn't that cost energy too? When you're using a TIVA, use up all these syringes and all this tubing, et cetera, et cetera. Yeah, it absolutely does use energy and it does impact the carbon footprint, but not as much. In this study, the authors used emissions data from the UK Department for Environment, Food and Rural Affairs to compare the total carbon footprint of a 7-hour anesthetic given with either a mixed propofol Remi-Tiva or a gas-based anesthetic using Siva or Des. They took into account the entire life cycle of the production of the propofol and remifentanil, as well as the disposal, as well as the carbon emissions for the production of the glass and the plastic that would be needed for delivery, and the disposal of all of that too. And the carbon footprint of using a propofol Tiva still is substantially less than a volatile-based anesthetic. But that's not kids. I hear you whispering to each other right now. Our cases are shorter. Our minute ventilation is way less. Our kids need so much propofol per kilo per minute. There is no way this could hold true for them. It actually does. This is a very meticulous modeling paper where the team did a very careful job of making a carbon footprint assessment using total life cycle data and accounted for almost every aspect of anesthesia delivery you could dream up. For the TIVA components specifically, they included all the things you see here. So the drugs themselves, the tubing sets, the infusion sets, the syringes, the vials, the incineration, et cetera, et cetera. And this is what they showed. In this study, the other thing that happened in this study is they also looked at many different sizes of kids. So, right, like a 5-kilo kid and a 55-kilo kid are different. And when you just say, oh, we use more syringes in a 55-kilo kid and we use a little bit, we can do low flows on both size kids, what about in that case? So this figure is a little confusing, but I'm going to orient you really quickly. Look at the gray and black lines. Those represent the carbon dioxide equivalents when volatile is given for two sizes of patients. The gray line is a 5 to 20 kilo patient, and the black line is a 30 to 50 kilo patient. You can see they just sort of linearly rise over time as the amount of gas is used, et cetera, et cetera. That's great. Okay. Now, there are these colored lines. The colored step-up lines each represent a different size of patient, and the step-up represents the contribution to the carbon dioxide footprint every time a new ampule of drug is opened. So all of that stuff that comes along with it, the making of the drug, the disposal of the drug, the syringe you have to use, et cetera, that's what these step-ups are. The divergence of the step-up lines from the diagonal line shows the difference in the carbon footprint between TIVA and gas. And so, as we mentioned before, and for those of you who are nitpicking a little bit, you would have noticed that the last slide looked at a 480-minute case, right? That's an awfully long case. Most of our cases are not that long. Most of them are much shorter. So here is a closer look at the first 60 minutes of a case. And you can actually see even here that there is still a discrepancy between the black and gray lines and the colored step-up lines. That study also modeled a lot more real-world scenarios because let's face it, right, even people who are super into TIVA sometimes find themselves doing mask inductions or a MIVA or something like that. And so they wanted to model situations where children got either inhalational induction and inhalational maintenance, which in this case is the gray and black lines, or an inhalational induction followed by TIVA maintenance, which again are these colored step-up lines for all these different sizes of kids. And you can see here, right, the TIVA maintenance may not be as carbon footprint sparing if the case is very, very short, but here are those lines represented as a table. And you can actually see that once you pass the 60-minute mark with a 20-kilogram kid, TIVA still has the lesser footprint. And as time goes on, and particularly like once you hit 120 minutes, that spread becomes even wider. So food for thought. So convinced yet? TIVA's better for kids, better for the earth. What more could you possibly need, right? I could just stop talking now. No. I'm actually going to convince you that TIVA is better for you. Because of this, maybe? Just kidding. Well, maybe not really. But why? Why is TIVA better for you? There are all sorts of reasons, but here are a few of my favorites. Let's face it, we are all a bit OCD or else we wouldn't be sitting in this room, right? Yes. Right, okay. Now that we agree on that, it's pretty easy for me to point out that being an anesthesiologist is an extremely socially acceptable way for us to indulge our OCD tendencies. And what better way to possibly satisfy that than giving ourselves a high degree of precision and control over our anesthetics? There's like nothing better than that, right? And Tiva actually gives us just that, a lot of control. Look at these pumps. Holy cow, you can set all sorts of things. They have all sorts of programs. Oh, wait. We don't have TCI in the US. We don't have those pumps with the models built in. You're right, we don't. But we do actually have ways to use the same modeling programs with our regular pumps, if we want, because there's some really fun and engaging apps that can help us mimic them. And they're actually super easy to use. They're available, some as desktop apps, some as mobile apps. The three I'm most familiar with are these three, the Stan Pump, the iTiva, and the Tiva Manager. And I have no association or like personal endorsement of any of them, but they do all use many of the published sophisticated TCI models, and some of those do include specifically children. So as that used to be a problem, it's not quite a problem anymore. So for those of us who love to tweak out on all the little aspects of drug delivery, Tiva, again, gives us the perfect way to do that, improving our own stimulation and our own satisfaction in the way that we take care of our patients. It's not just like, oh, you go like this. Okay. And obviously, because we're people who get super obsessed with thinking about the complexities of caring for our patients, we probably want to keep our brains in tip-top shape so we can do all this obsessing and do all this precision delivery of our anesthetics. And while we do know that our anesthesia machines have scavenging systems built into them, and we also know that the operating room have built-in airflow and scavenging in mind, there is no doubt that we are still exposing ourselves and all of the OR personnel to various anesthetic gases when we use inhalational anesthesia. And the effects of these gases over time are not benign, at least on the cellular level. In this interesting study, 60 anesthesiologists and 57 control physicians who were of similar age and lifestyle donated their exfoliated cheek cells to 2 different types of in vitro assays measuring DNA damage by various markers. The assays looked at things like micronucleus, which is a marker of genomic instability and rearrangement, karyohexis and pycnosis, which are signs that cell death is occurring, and a decreased overall number of basal cells in the samples, which matters because those are a source of unipotent stem cells, and if there are fewer of them present, the overall epithelial turnover can be damaged. And you can easily see here that there is an increase in all of those bad things in the physicians in the exposed group versus those in the control group. So if we could decrease our exposure, that would be great.
Okay, 8%. 8%. Okay, beta. Okay. Sarah, good boy. Good boy. Okay.
I can't make him stop. Hold on. I don't know. Hold on. I couldn't make him. I just can't make him stop. There we go. Okay, sorry. Whew. My goal was to make that play a little bit longer than anyone wanted so that everyone would start to feel a little bit squirmy, but it wasn't actually to make it keep starting over and over again. Sorry about that. But I did want to play that a little bit longer because I actually hate watching that video, and I imagine you guys all hated watching that video too. It like makes me cringe and squirm. But I know that all of us have had that kind of experience, right? Some inhalational inductions go like that. There's a frantic kid, they're screaming, the mask is smelly, they're wriggling out of the arms of the provider, the gas is going everywhere. And we were just talking about how toxic potentially the gases are, but there's not much control. Nobody wants that to be happening. And on top of it all, nobody's having any fun, right? That's not a good experience for you. It's not a good experience for your OR colleagues. And it's not a good experience for the kid, right? And it doesn't have to be that way. Whew, okay, PTSD, sorry everyone. So what if it could be different, right? Picture something else. Picture this. Picture a kid walking into the operating room on their own 2 feet. They jump up onto the table. They're happy. They're watching their iPad. Their mom is there. There's some child life person blowing bubbles. You gently remove 2 patches of snow cream from their hands. You wipe it away. Mom or dad hugs them gently. They pull the hand behind and they keep watching their iPad. A nurse gives their forearm a little hug, and you pop in a teeny tiny
Hand
tubie.
again. You feel a little pressure. Good job. You're doing awesome. Did you feel that a little bit? Try to hold still. You're doing awesome. That's it. We're all done. We're just going to put our sticker in place.
Right? Okay. That was at our institution last week. So, you do that. You pop on some teddy bear stickers. You show the kid. You pull out some sleepy milk. You give them 1 to 2 per kilo of sleepy milk. The child yawns. They gently close their eyes. The parent lays their head down on the donut, gives them a kiss, is ushered out by a nurse or a surgeon somewhere. There's no coughing, there's no muscle jerking, there's nice peaceful dreams, and then you give whatever else you want to give. You give more propofol, you give some remifentanil, right? The kid's apneic, you move on. So satisfying, right? We'd all take that probably every time over the first video. And that's what you can get with Tiva. So that was a lot. My time is up. There's a lot to say about Tiva and why it's the superior choice. I could go on for longer, but I'm going to let Kirk say something, obviously. But to me, it's very clear why Tiva for Pediatrics is the winner. It's better for our patients, it's better for the world, it's better for you. And honestly, if doing better and making things better is not the reason why we go to work every single day, I am not sure what is. So thank you guys for letting me talk about Tiva, and I will hand over to Kirk.
Good afternoon, everyone. Thank you for being here. And by the way, nice repeat on that video, Dr. Carell. So carefully curated, of course. I mean, I felt like going and having an IV myself. It was like awesome. All right. We don't seem to be working here.
You have to click on that.
Okay. So I do have some disclosures. I'm a common shareholder in healthcare companies, but none of them are going to be mentioned in today's presentation. And our objectives for today are going to be several-fold. First, we're going to highlight the advantages of inhalational anesthesia over Tiva. Then I'm going to try and convince the tiny minority of you Tiva diehards, Simon, I'm looking at you, that you're barking up the wrong tree, you've got the wrong end of the stick, and you've been conned by fake news. I will also help you save the planet by avoiding the manufacture, disposal, and incineration of billions of 50 ml syringes, gazillions of propofol bottles, hundreds of miles of extension tubing, and avoiding tens of thousands of gallons of propofol from entering our water table and poisoning aquatic life forms. In the process, you will save your practice a lot of money. Now, man has come a long way since the invention of fire and the wheel. These discoveries by our ancestors were not necessarily out of idleness, but probably for a need, right? They needed warmth, they needed light, they needed to cook food. The invention of the wheel is really interesting. I don't know if you know, but it was invented about 3,500 years BC in Mesopotamia, which is current-day Iraq, and it originated from the potter's wheel. Somebody had the bright idea of like, oh, look at this wheel, we're making pottery. Maybe we can use this to move heavy objects. And, you know, thus the pyramids were born, because they were able to move those giant blocks of stone on these rollers. Next year will be the 40th anniversary of the discovery of propofol. And propofol was discovered because it was something that needed to be better than sodium thiopental, which is what we had in those days. Had all kinds of side effects. Not a great drug. Some of you have no doubt used it. But ever since inhalational anesthesia was popularized by pioneers like John Snow, who is known as the father of anesthesiology and the father of epidemiology, I'm sure all of you know the story of the Broad Street water pump and how he traced cholera back to that one pump and found that it was a waterborne disease. plus his exploits giving chloroform and ether. He wrote 2 treatises on that, gave 4,000 anesthetics in his lifetime, was the first physician to dedicate his practice to anesthesia, gave anesthesia for Queen Victoria's 2 deliveries as well, or 2 of her deliveries. So we've come a long way since then. We now use a lot of insoluble agents, and we have many, many safety mechanisms built into our vaporizers, unlike this Schimmelbusch mask and open drop ether, which used to be used where you would just pour the ether on top of the mask and kind of look at the 4 stages and gauge how much ether you needed to drip onto this mask. So let's talk a little bit about some of the advantages. Well, the first is comfort. That video notwithstanding, kids do not like IVs. We'll come to that in a minute. Safety, controllability, operational simplicity, cost effectiveness, stability for organs and hemodynamically, and then we'll talk a little bit about some of the common misconceptions of TIVA. Excuse me. So the elephant in the room is trypanophobia, needle phobia. Kids hate IVs. They hate shots. Eventually, some kids end up hating hospitals and us. Some of them are abjectly terrified of shots, as are many adults. You can see the incidence of fear of needles in adults is 22%. And it's very strong in kids, 50 to 70%. Do we really want to traumatize, torture, and terrify all the infants, toddlers, and school-age children just because we want to say, you know what, I'm going to use TIVA, therefore you need an IV? Think of your busy ENT days where you have 10, maybe 15 cases, and think about whether you want to place an IV on every one of those kids. And trypanophobia and needle phobia is not just fear and anxiety, it actually has real-world consequences. Fainting and vasovagal events are associated with needle phobia frequently in adults, adolescents, as well as in some children. And this is the only phobia, incidentally, where this is actually a feature, which is really interesting. But it does lead to avoidance of medical treatment, avoidance of dental treatment, dialysis, insulin therapy, fear of hospitals, doctors, and this is true even in healthcare workers. And of course, as you've seen, we have to use topical anesthetics. Frequently, we have to use pre-medication to avoid the scene like you saw in the first video. And that's pretty widespread. So ask yourself, do you want to be dealing with this 10 or 15 times a day? This is a problem. Or would you rather be the architect of this? Remember, this is not restricted to children, right? Teenagers, adolescents, and adults have a very hard time with IVs sometimes. So do you want to be in a situation like this, where you're trying to place an IV? The trauma is undeniable. And sometimes patients take things into their own hands. And they have a flight response. And they will run away. They're like, I am sick of being poked and prodded. I'm out of here. All right, let's talk about safety. So there are several layers of safety measures that are built into our machines and our vaporizers, right? There is no safety net for TIVA. There is nothing to tell us that there's going to be a pump failure, a disconnection, subcutaneous infiltration. We don't know what the actual dose of TIVA is inside the body, what the plasma site concentration is. We guess. Canada has TCI, so they actually have a pharmacokinetic model. But even with that pharmacokinetic model, there's tremendous variability in children. So we have no idea how much anesthetic we're actually giving a child. Those variations in plasma concentrations that are effective are huge when it comes to young children. So this is a huge problem, because if you had a disconnection, you could have awareness in a paralyzed child. You could have movement in an unparalyzed child. Now, we were talking earlier before this, and they confided to me that they do use BIS monitoring in paralyzed patients. BIS is notoriously unreliable. 70% of the number that BIS gives you with propofol anesthesia in children has got nothing to do with the dose of propofol being given. So it is unreliable. And that has been shown over and over again. How about prolonged cases? We know that propofol can sometimes result in propofol infusion syndrome. This is a real problem. This was first, not diagnosed, but the first time it happened was when they were using propofol for sedation on the pediatric intensive care unit. And they had these unexplained kids with myopathies, and they ended up dying from cardiac failure. And this is because propofol uncouples the oxidative chain in your mitochondria with long cases. And you don't have to have mitochondrial disease for this to happen. So that's another issue with long cases done with propofols. The other thing is that you can also have programming errors, right? You can have infiltrated IVs. What about difficult venous access? What about drug-specific toxicity? What if someone has mitochondrial disease? The general advice these days is, okay, if initial dose of propofol is probably fine, but you probably shouldn't use propofol infusions for long periods of time in children with mitochondrial disease, again, because it affects complexes 1, 2, and 4. Difficult airways, kids with asthma, bronchospasm, sevoflurane is great, right? The other thing is volatile agents satisfy, to some degree, all 4 requirements of an ideal anesthetic agent, right? They produce amnesia, loss of consciousness, they have some mild analgesic effects, they do ablate baroreceptor responses to some degree, and they provide some muscle relaxation. And you can do cases without using opioids and having minimal movement. Here's one example. So this is a randomized controlled study that was done for rigid bronchoscopy for foreign body extraction. Half the kids were randomized to TIVA, half were randomized to inhalational anesthesia. The time to loss of consciousness and to a BIS of 40, as well as emergence, were all less in the inhalational anesthesia group compared to TIVA. There was less desaturation and less breath holding. Their conclusion was more stable hemodynamics and respiration, faster induction and recovery. What about controllability? We can rapidly change the depth of anesthesia with inhalational anesthetics. This is not necessarily possible with propofol without giving a bolus, and sometimes that causes apnea when you least want it. There's quick wash-in, quick wash-out. We can wake kids up really quickly. We can turn rooms over very fast. If you give propofol for longer cases, the time it takes for it to wear off is very inconsistent. Plus, we have MAC monitoring. We have direct, continuous, real-time monitoring of anesthetic depth via end-tidal agent concentrations. No such system exists for TIVA. So we're really grasping straws in the dark. We don't know how much we're giving. Is it enough? Are we overdosing? Are we underdosing? So inherently, TIVA is less controllable, right? Because it works on this effect site concentration, which if you have TCI, is built into those pharmacokinetic models. But again, there's tremendous variability. For us here in the US, or if you don't use TCI in your practice, you're completely in the dark. You're like, oh, okay, we're going to do a TIVA. How much should we do? 150, 200, 175? Well, let's pick a number, something above 150, right? So we don't know, are we actually giving them too much, too little, not enough? What's going on? No idea. All right, let's turn to cost effectiveness. So inhalational anesthetics can be cheaper. Time is money, right? Especially nowadays with hospitals having increased demands for throughput of cases, the increased clinical load that all of us are facing, and in the US, decreasing reimbursements for cases, as well as increased costs for goods and for salaries, right? So how do we work this out in terms of cost? Well, think of the setup time, right? So you've got to sit down, you've got to draw up your infusions, you have to program your pumps, you need preoperative IVs, sometimes you'll need a pre-med for that, you'll need 1 hour for the cream to work or 20 minutes. You need hardware that costs money, so you need a ton of extra pumps. You need that infusion tubing, you need those syringes, you need lots and lots of propofol. You heard how propofol is basically weight dependent, right, the dose. So a 100 kilo kid compared to a 20 kilo kid, you need 5 times the amount of propofol and 5 times the amount of remifentanil. Some of the studies that I'm going to show you with related to cost, they peg the cost of a vial of remifentanil at €7 a vial. In the US, it's 30 to 60 for a generic version. So vast difference in cost. And then, of course, you may want to use depth of anesthesia monitoring as well. And we know that recovery is typically faster, particularly for longer cases where propofol is a little inconsistent. And all this means reduced throughput, fewer cases, and increased staffing potentialities. We talked about the weight dependency of propofol dosing, and then we haven't come to the recycling part, right? So we have all these syringes and this tubing and a lot of wasted propofol. We'll talk about that in a minute, and we'll also talk about incineration of propofol. So this is a study from Holland by Reef. And they looked at 349 procedures from their hospital, every operating room, over 7 days. And they measured the amount of wastage. They collected all the syringes, all the tubing, everything that was, taken out, not used, partially used, and they collected all the waste. And what did they find? 22% of the propofol that was utilized was actually wasted, and 14% of the remifentanil. These numbers are as high as 50% in other studies. So 30 to 50% is a rough estimate. They were actually, I think, doing pretty good at 22% of propofol. But that's a lot of wasted propofol and remifentanil in addition to these other things that are wasted. Excuse me. Okay, they also then quantified the cost. Now remember, we're talking about $7 a vial of remifentanil. 7,000 euros in 1 week. And what does that equate to? In a year, $432,000 of wasted medications in one hospital. And again, these numbers will be significantly higher if you do more procedures, because there's more waste, right? And the cost of remifentanil will put those numbers easily into 7 figures for any average-sized hospital. All right, so Dr. Curl talked all about the environmental friendliness. And yes, I'll give her that. Greenhouse gases, no question, Tiva is better. I'm not disputing that. However, there's also the cost of production, packaging, transport, the syringes, the disposables, the pumps, the energy required to produce all that, the emissions, and also the disposal and the incineration, plus the wastage, which we've already seen. So if you were to use sevoflurane, no nitrous, and this is where excuse me, I differ from some of the studies she showed. I gave up using nitrous oxide years and years ago. And as a pediatric anesthesiologist, if I can do it, anyone can do it, right? I mean, you don't need nitrous. So if you don't use nitrous and you use low-flow sevoflurane, there is no material waste. Yes, you do have some greenhouse gas emissions, of course, and it's about 3 or 4 times higher than using propofol. But there's a caveat, and we'll come to that. Briefly about the recovery profile, the PONV thing. Yes, there is less PONV with Tiva, and this is particularly relevant in adults, right? But when you compare it to inhalational anesthesia, there is a study in 2005, a meta-analysis that shows if you use a volatile agent and one antiemetic agent in children, it's equivalent. Why? Because PONV is far less common in children than it is in adults. Proportionally, as you get younger, it's less common. So this is an advantage which is less for shorter cases and younger children. What about emergence delirium? Those of you who at the SPA meeting heard Dr. Andrew Davidson talk about one of the studies where emergence delirium was quoted to be as high as 80%, and he ridiculed that. It's nowhere close to that. It's probably more like 10%. And nowadays, I don't know about your hospital, we use dexmedetomidine like water. Literally every single patient gets it. So the incidence of emergence delirium is probably below 5%. So again, not much advantage there. Well, what about the environment? Propofol was the second most administered drug, and it has been found in wastewater treatment plants all over. One thing about propofol is only 1% is actually excreted unchanged. 60% is glucuronidated in the liver, right? So people thought, well, if we look at the wastewater concentration of propofol, and it seems to be pretty low, we're okay. But what they didn't realize is the influx into these wastewater plants is very different from the efflux. So what's happening in this water treatment plant is some of that propofol, which is in the glucuronidated form, I'm sorry, I can't say that, has been deglucuronidated in the wastewater treatment plant. So in fact, the estimates of how much propofol we are releasing into the environment currently could be 60 times higher, because 60% metabolized, 1% unchanged. But if a lot of that is going to go back to native propofol as it leaves the wastewater plant, that could be a tremendous environmental catastrophe. So that's something to think about. And why should we think about this? Because it is toxic. Propofol is ecotoxic. It causes developmental toxicity, neurotoxicity, oxidative stress, and apoptosis in zebrafish embryos in the lab, small crustaceans, algae, and other freshwater fish like rainbow trout. We know this for a fact. What we don't know is, how do we actually stop this? How do you stop propofol from being released into the environment? The current water treatment processes are not adequate. To completely rid yourself of propofol from water, you have to incinerate it at 1,000 degrees for 2 seconds to completely get rid of that molecule. And that is a problem that we will have to deal with should we make a large-scale transition to TIVA. It accumulates in aquatic life too. By the way, propofol has been found in French wastewater treatment plants. It has been found in textile floor coverings. So it's already in the environment. It's in the aquifers. It's in the aquatic bodies of water that are like scattered around the countries. And it accumulates because it's lipophilic. So it goes into tissues and it takes a while to get out. The half-life of propofol, it is not metabolized naturally by sunlight and water or anything like that. The half-life is 1 year. So it is ecotoxic. It is a persistent pollutant. It is not readily biodegradable. And there's the other matter of EDTA, which is a preservative in propofol. We haven't even begun to talk about that. So TIVA with propofol, yes, if you want to completely minimize greenhouse gases, that is what you should be doing. But we'll always need volatile anesthesia for some of the things we already talked about. And if we use TIVA exclusively and make this massive shift, it could lead, and this is from an article, it could lead to stock depletion, plastic pollution, and water contamination, as we've seen before. In the EU, environmentally hazardous substances are classified and labeled and packaged under specific legislation known as CLP regulation. Under this system, propofol is associated with H410, very toxic to aquatic life with long-lasting effects. This is a huge problem in places that don't have a lot of water. It's a problem everywhere, but it's an even bigger problem if it contaminates the only aquifer that supplies a city which is in the middle of a desert or far from natural water sources. So waste reduction should be prioritized because the best waste is that which is not produced. So do we really want to produce so much more waste, which is going to end up in our landfills and our water? This is before we've even talked about the new kid on the block. This is the dynamic gas scavenging system, which has now got FDA approval. Amazing, right? And it is claimed to extract 90 to 95% of used volatile anesthetics from your circuit, which will make this whole greenhouse gas thing go away. It's not yet commercially on the market because they're still refining the second thing over here, the anesthetic recapture system, but watch this space because this could be huge if it is truly as efficacious as they say it is. Well, what about organ protection and stuff? Well, we know that volatile agents decrease CMRO2, right? They do increase cerebral blood flow in a dose-dependent fashion. And there was lots of talk and lots of, is it cardioprotective and, ischemic preconditioning, all that stuff in adults. And it's been found that they're pretty much equivocal. There's no significant advantage of propofol over inhalation anesthetics in terms of neurotoxicity or protecting the brain, or protecting the heart. And similarly for propofol. It is eliminated by the lungs. It does not depend on kidney and liver function. So that's one advantage. If you have somebody with bad liver function or bad kidney function, potentially inhalation anesthetic should not make much of a difference. We talked about mitochondrial diseases, where long duration infusions of propofol will probably be dangerous. And we like it for asthmatics and people who are more likely to go into bronchospasm. But overall, there's less patient movement. You don't need to use lidocaine for the pain of propofol. You can keep them breathing spontaneously. They're great for airways, foreign bodies, difficult airways, anterior mediastinal masses, right? Rapid changes in depth of anesthesia, easily accomplished. Easy, quick setup, less plastic, no programming pumps, no worry about disconnections, subcutaneous infiltrations, kids waking up in the middle, awareness. And depth of anesthesia monitoring, which does not exist for TIVA, is built into every anesthetic system that we use. It's there. You can see how much volatile agent is in the patient. This is a great study, hot off the press, 2025. This study was done in 3 French hospitals. And the first hospital used a TIVA-only strategy, more than 99%. Second, sevoflurane with a target-controlled endpoint. And the third, sevoflurane with a clinical endpoint. And they compared the 3 things, patient, planet, profit. Most important thing is your patient. So what were the outcomes for patients? Again, some of these were adults, right? Most of them. Less PONV, for sure. We know that. Less relevant in children. What about for the planet? We talked about greenhouse gases and how, yes, I totally admit, greenhouse gases emissions with inhalational anesthetics, even with low flow and no nitrous, is definitely higher than propofol. But again, that's not taking into account the water table, the ecotoxicity, and the contamination. And what's going to happen if every single one of us goes to TIVA on 100%? And finally, profit. They also talked about cost, and the cost is roughly the same for both, except it didn't take into account, again, what do you do about all this wasted propofol, wasted remifentanil? How do you dispose of this propofol? Are we actually going to be incinerating millions of gallons of this stuff? It's going to cost a fortune. So everything's up in the air. So we know it's safe to use inhalational anesthetics, and there's some things that we can avoid that are, I wouldn't say common with TIVA, but can happen with TIVA. It's easy, it's convenient, it's reliable, it avoids IV placement. We can induce kids with difficult veins really easily. It facilitates us doing short cases with no IVs. Think of all your ear tubes. Do you want to put IVs in all of them and do IV inductions in all your ear tubes? I got one convert over here. So it prevents movement without the need for opioids. It's better for airway cases. You can keep the patient breathing spontaneously. If they get light, you don't have to give them a bolus. Then they go apneic, and then you've got like, oh, I need to put a tube in, all this stuff. I've seen some people who do that, and it's a disaster. It may be cheaper once you take into account all the wastage and all the destruction of the leftover propofol. It is, for sure, worse than TIVA for greenhouse gases, but it doesn't contaminate our landfills and our water supplies. And the recovery profile in children, again, because of the lower incidence of PONV and the fact that we're using a lot of dexmedetomidine, really doesn't make that much difference. It's not that different. So I'll leave it to you to decide, and that's an AI-generated picture, or 2 pictures, of propofol fighting sevoflurane. Thank you.
Fantastic. Thank you both. This was very enlightening, and appreciate both hearing from both of you on both approaches. So I'd invite the audience to come to the mic with any questions that you might have for our experts. If you do come to the mic, do introduce yourself and where you're coming from, and please don't be shy. In the meantime, I'll start off with a couple of questions for our experts here. So one of them I'll start with Dr. Carell. So, and I'm just going to make an assumption here that you may be in minority, though maybe as people leave the room, you might have made some converts. Inhalation induction and inhalation anesthesia is still sort of the favorite approach in pediatrics. And it doesn't mean that we can't switch, but I do have concerns about what do you do with some of the more anxious children. I mean, you showed us a little girl that was, easily comforted, or some of our children with some developmental delays, and any advice that you can share.
Yeah, totally. This is on. Okay. So a lot of these are systems issues, right? If you create a system where in the pre-op phone call, the family and the child are promised no shots or pokes or needles or ouchies, the family and the child are going to come to your facility expecting no shots or pokes or needles or ouchies. And once that has happened, it's not great to break that trust, right? You as an anesthesiologist have 32 seconds to develop an amazing rapport with some child who's going to be given to you by their parents. Now, if you don't do that, if your pre-op phone call, if your nursing phone call tells everybody about snow cream and tells them all about blowing bubbles and about playing on the iPad and this and the other thing, then you set up your system differently. And actually, at our place, our system is set up very differently. Our system is set up primarily to have cream put on all the patients, have all the parents come back to the OR. All the parents are talked to by the nurses in the pre-op area about what a comfort hold is and how to hold a kid who's getting an IV. We don't use tourniquets in the OR. Most of our kids are small enough that the nurses or our helpers in the OR will just make a tourniquet with a thumb. And so if you set your system up to create success in this area, you can have success in this area. It's really difficult to be the only one at your place trying to do something if your system is set up the other way. So I'm not going to pretend that like every single kid could always do this. There are other things too. So we are lucky enough to have a number of child life folks who are educated in some integrative medicine techniques, and I don't know if people have heard of the hypnosis technique called the magic glove, but we actually have a number of folks who do clinical hypnosis and magic glove for kids, which is evidence-based, tactical or tactile way to create less sensation in, let's say, the back of a hand or something for a kid who's getting an IV. And we do occasionally give kids pre-medications, but I would argue that the kids who get the pre-medications because they're going to get an IV induction are probably going to need the pre-medication for a mask induction too. So I don't think that it's that much different. But you need your system to support you. And if your system's not going to support that, then it's going to be difficult. When our families come to the OR, oftentimes what I hear is, you're not going to suffocate my kid with a mask, right? You're not going to shove something on their face so they can't breathe.
Because you saw that video.
Well, anyway, that video, that's not our place. That was somewhere on YouTube available to anybody. But like, it's all about how you frame it, right? If you frame it that shots and pokes and needles and ouchies are the worst thing in the world, then that's what your family's going to think. If you frame it that putting a mask on and suffocating the kid with smelly gas and making them feel like they're choking is the worst thing in the world, then that's what they're going to experience.
See, we have a question.
Great presentations, both of you. Neil Campbell's my name. I'm a pediatric anesthesiologist in Kansas City at Children's Mercy Hospital. Every time this subject comes up, I think of colleagues, even myself when I was younger, in the context of teenage patients who can choose for themselves. And when the risk profile is roughly the same, my question to them is, which would you choose? Which then brings me to one of those classic papers that we all know of, which is the 4 models of patient-physician relationships. And when it comes to systems and pushing a system, potentially pushing a system onto a patient and family versus giving them a choice, I'm wondering how your thought processes are influenced by that paper with the paternalistic model of patient-physician relationships. To say that one is better than the other when the risk profile is the same is the context that I would hope that you could speak from when you answer the question. But that's really what comes to mind. And the last comment I'll make is that I see this frequently in my young colleagues who have a hard age cutoff that say when you turn 13, you're going to get an IV preoperatively, and we're going to put that in whether or not it's tough or not. Just curious if you could talk about that.
I take your point very well. That's a great aspect that I guess we didn't really touch upon. Patient autonomy is huge, right? And if I may disagree with Dr. Correll here when she said that if the kid needed a pre-med for an IV, he probably would have needed it for gas too. I think I have had hundreds of children who would be only too happy to blow up the balloon, paint their mask, put stickers on it, and not have to have an IV. It is pervasive and it is frequent. So yes, giving them the choice is important. We too have cutoff for IVs. It's 12 years and 40 kilos, both. But we are flexible. So if we have a 13 or 14-year-old and they're like, do anything but don't put an IV, sure, we'll do an inhalational induction. We can do a single breath vital capacity induction, and it's fine. You know, so you have to be flexible. I don't think there's any one good system is better than the other and we're only going to use this and not going to use that. You have to be able to do both. Just like if we have a patient, a teenager who comes in and says, the last time I had an anesthetic, I puked for 3 days. Well, we'll do a TIVA. Of course we'll do a TIVA, right?
Yeah. I'd agree.
So thank you for bringing that up. And actually, I think Kirk and I agree on lots of things in the world. So there are many things that we agree on. And I very much strongly take your point about patient autonomy, particularly as kids become older and are beyond just sort of assent. They're really more at sort of mature adolescence and stuff. And a couple of things happened. I used to be in a system that was very much inhalational induction until just a few years ago. And I was very satisfied with my system. And I have a game on my phone, and the kids blow up the balloon on the game, and the balloon explodes. And then, I tell the kid if they can explode 4 balloons before they fall asleep, they get a prize. Like, that was fine. I had plenty of cooperation. And I'm not sure that I really believed if somebody had told me, oh, you're going to move to this place, we're going to do 90% inhalational or IV inductions, and the kids are going to be fine with it. I wouldn't have believed it. But they are fine with it. Now, that said, we do have a number of kids, teenagers, littler kids, whatever, who have particular preferences. And if kids or families express particular preferences, then we will typically go with that unless there is a compelling, probably safety-related reason to not. I will take some issue to the argument that the risk profile is the same between an inhalational and an IV induction. I think there is a group of kids for whom the risk profile is probably exactly the same. But I think there is actually a relatively large group of kids for whom that risk profile is not the same. And that Ramglam paper actually highlighted some things that I never really thought about living in upstate New York, where there's an extremely high prevalence of secondhand smoke exposure in the home, high levels of asthma, winter URIs, et cetera, where I actually think that the risk profile can be different, more different than maybe some of the more controlled papers would suggest. So in those kids, if there is a really compelling reason why one is safer than the other, I will say to the family, there are 2 ways typically to go off to sleep with anesthesia. One is with a little teeny tiny tubie, and you've got your cream on for that. And the other is breathing through a mask. In the case of your child in particular, today, I think those are equivalently safe. Or in the case of your child particularly today, who lives in a place where there is smoke exposure, or who just recently had a cold, there probably is a little bit more safety with the IV. That said, that safety might go away if I try to put the IV and the kid becomes really, really distressed and they start screaming and crying and wriggling all over the place, right? I will say to the family, I'm not here to make your kid distressed. That's not my goal. If I find that your child is becoming really distressed, or you do, in the OR, because they're all with us there, then we will switch. And that's usually, it's not so much giving them the choice, but it is giving them the information and the motivation for what we're doing. And I think most people are pretty happy with that. I think giving them the choice is sometimes more stressful because they're like, you're the expert. I don't know. I just showed up here with my kid. I'm supposed to trust you. I'm going to leave my kid and leave it to go to this other room. Like, you're giving me a choice? Like, shouldn't you know what to do?
Thank you. Shazia.
Thank you so much for this great presentation. It's very enlightening. I'm Shazia Mohammed. I'm a pediatric anesthesiologist at Texas Children's Hospital. So I had a question for both of you guys. Kurt, we personally use TIVA for MRI scanners, and there's online versions of this, but there's a tool called calculators that can make for 2 hours if I run this rate for this weight. This is exactly how much propofol I need, and I typically don't even waste maybe an ml, 1 ml of propofol in that instant. That paper that you cited, were they using some type of propofol calculator, or were they just spiking a new tube every single, like, new bottle, I should say, every time, and then whatever was left was being wasted? And then question for Lynn, since you've seen both sides, do you feel like doing the IV induction with bubbles and cream, has that process increased your time for induction, bringing them back? How's that a time cost been for you guys?
So to the first part on the Reef paper, I don't know exactly what they were doing. They didn't go into that much detail, but they basically collected all the waste that was remaining in the OR after every case, and they did this for a week. So it could be that, yes, some things were spiked and never used, and other things were partially used. So I don't really know the answer to that.
So your question was just based on having experience in both, do I feel like one is much more smooth than the other? Is that the question? Oh, timing. Okay.
Time.
Obviously, we all know that there are lots of different factors that go into making our operating rooms more or less efficient. My switch to a place that does primarily TIVA also involved a switch to a socialized medicine system because I live in Canada now. The production pressures in a socialized medicine system are very different and driven by different things than the production pressures at, let's say, your ASC in New York. I used to work at an ASC that would do 13 to 15 TNA/ear tube cases a day. We don't do that. The reason is not because it takes us so long to get the kids to go off to sleep or wake them up. The reason is lots of other things, like in a socialized healthcare system, surgery costs money. In a US healthcare system, surgery makes money. So there are lots of things. Does it take a little bit longer for the parent to come back to hold the kid, to put the IV in, to give them a kiss, and to walk out the door? Maybe. But does it take me a lot of time to, in between cases, when my kid is screaming in PACU because they have emergence delirium, attend to them, make sure they settle down, make sure they're not crawling up the shades of the window, make sure they're not screaming, the family's not distressed? I would say that one laryngospasm on the way from the OR to PACU slows my day down a lot more than the extra minute or two here and there of bringing a parent back and doing the IV induction. Yeah, sure.
Thank you so much. Great, really great debate and well done. I will say just what you were just speaking about, so in CHIO, mainly inhalation induction, I was at kids back in the day, mainly IV induction, so I do both. Dexmedetomidine, game changer for emergence delirium and inhalation induction environments.
Yep. I agree with that.
That's really a big issue. One thing that I haven't heard here in the Africa study shows very clearly that experience counts from a safety perspective. So for each year of experience that you have, you can increase your risk of praise by 1%. So those of us that have been doing this for a long time, regardless of whatever induction agent you use, your risk of complications is going to be less because you will be able to avoid putting in that oral airway too early in that patient with an inhalation induction that has a cold. You have the experience. The final thing is just a question, and I mentioned this to Simon, with the IV inductions that I do with propofol, parent in there, I will do a ear block with lidocaine so that the last thought of the parent as they're walking out of the room and hearing your child cry as they're going off to sleep with the propofol burning their vein. So just my question to you, when you're doing IV inductions with propofol, is there any mitigation strategies that you do to prevent the crying that the parent has to address and remembers for the rest of the day?
Yeah, so thanks, Kimo. So yeah, I mean, obviously in adults, we also know that when you go off to sleep with propofol, it can burn. Most folks will put some lidocaine in the propofol, or they will do a little bit of a beer block. I tend to do the beer block. But the other thing is the talking, right? So expectation setting, even with young kids and family members, is really important. Somebody's entire experience can be changed by the stories they tell themselves and by the stories that I tell them. So in addition to doing maybe a favorite place hypnosis, I often talk to kids about going on vacation to the beach and the sun is shining on their hand and their hand might feel a little bit warm, but they're going to drift off to sleep. And at the end, they're going to wake up on the beach or wherever they want to be in their favorite place or something like that. So the words we use matter, and the way we use those words matter a lot. And I think that often can mitigate potential distress.
Great. Thank you. And we're going to take our last question.
You're the best for the last. Zulfikar Ahmed, Pediatrics in Trinity Health, Michigan. I think the biggest limitation may be implementation of TIVA in US compared to other countries, especially the use of target control infusion. And in the essence of target control infusion, how would they recommend we use the system in our, if we want to use it in some patients?
Sure. So that's a great question. TCI is approved in Canada, but we don't use it at our hospital. We do almost entirely all manual TIVA. Some people who are nerdy like me maybe goof around with some of the apps that I was talking about, but actually most people don't. Most people, most people sort of learn while doing, and we learn from our colleagues, and we teach our trainees how to be efficient and how to calculate the amount that we need so as not to waste a lot and not to actually use TCI. The models are variable, so there are TCI models that do include children, and the newest one I think is Eleveld, and that one does include lots of different size children, and so that one's actually quite good. And the app, that iTiva app that I mentioned, does have Eleveld built in, so you can use that. But with practice and time, and Simon has more practice and time than I, and you can certainly talk to him too, we find at our place that we don't tend to use the models that much. And, you know, with time and practice, that tends to be enough. It does take a little bit of time to get really good. I'm not sure I'm really good yet, but I'm getting much, much better. And, you know, anybody can if they do it enough.
I'd agree with that. I just started using Alavel for some of our TIVA cases, especially playing around with spines. There's a learning curve, like everything, but the sooner you get on it, the quicker you'll really get it.
So Eleveld is a model that was published that incorporates lots of different sizes and ages of patients, but does include children. And so some of the TCI pumps that people who use TCI use can incorporate that model. There are some other models that include children like PedFuser and Kitaria, and they all have advantages and disadvantages, but it's all published stuff, and you can certainly look it up. And if you want to use one of these little iPhone apps, you can tell it which model you would like it to emulate, and then you can kind of use it.
Or you can bring it up on your computer, like on in the OR as a teaching tool. It's free, and it does go down to, I think, I forget if it's 2 years or 6 months, but it's.
You don't. You can bring it up on the screen, and then you follow it as like a stepwise instruction if you wanted to.
You put in the weight of the patient, if you're using opioids, or it asks you, it really walks you through step by step what you should do, and really how long till wake up. So it really tells you when you should really start dialing down, which is really the tough part for those who are not familiar with TIVA, is knowing when to stop or almost stop.
Eleveld is Eleveld, but the iTiva app, which is free, I think, or it's very inexpensive, can include that model among others. I think it also has Kitaria and PedFuser.
I think we're going to stop here. A round of applause for our speakers. Thank you for staying till the end.